First talk is by Dr. Nishant, and Nishant is a prolific surgeon. He's a young dynamo. He's so good, and he's one of the best we have in our state, Gujarat state. So, Nishant, please take over.
Are you able to see my screen?
Yes, yes.
Okay. A very good morning to one and all. Professor Namrata Sharma and Dr. Rajesh Sinha, they have been doing such stupendous work since last 2 years tirelessly, providing us at our doorstep all the knowledge that we need, and we are being updated. Dr. Abhay Vasavda, I have been learning from him since last 2 decades, and his passions for perfection, probably all epitomes are short to describe it. He is an inspiration, a true living legend. Dr. Vavikar sir, Dr. Abhijit Desai, Dr. Shail, and Dr. Vaishali. Uh, my topic today is to talk about the basics of presbyopia correcting IOLs. So, as sir said, presbyopia correcting IOL is probably the next big thing in ophthalmology. I was just going through the literature to refresh myself, and I was feeling short of the count of the number of IOLs which are into the pipeline to treat presbyopia. We all probably will have to cease to be a clinician for a few minutes and dwell the thinking cap of a physicist to understand a bit better of how the IOL works. Light basically has been described to have two theories, the particle and the wave theory is what is responsible for the refraction of light inside the eye. So this is what is imperative. We all know that for a normal eye, when you have an eye which is able to see properly a normal young lens, it is able to focus for both distance as well as for near objects precisely. But once presbyopia steps in, the distance focus is crisp, but the near focus is slightly out of the focus. And if we want to really mimic a young lens, as of now, the principles of physics prelude us to do that. But there is a bit of compromise which can happen, and that is what is aimed for by all presbyopia correcting technology. So instead of a single point focus, you can say there is a channel or a blurred circle which is there, which is being aimed to focus in front and behind the retina to create an area of extended depth of focus and by giving extended range of vision. It is being taken care of differently by different IOLs. If we take the channel concept as a whole, if you see the lesser the diameter of the channel, the better would be the visual acuity. The longer the depth of the channel, the better would be the range of vision. The more the light enters in the channel, the more it would be like music to the eyes. The more the light goes outside, it would be like a light pollution or noise to the eye. So this is the basic concepts which we need to keep in mind while we discuss different IOLs. The first and the foremost is the small aperture IOL. It is kind of an opaque mask which is put in the place of a lens, which reduces all the peripheral light and focuses the central light, thereby giving a concentrated beam. However, the problem here occurs in mesopic condition when the eye needs more light. So whenever used, normally it is used for one eye only. The second concept is a spherical aberration changing IOLs. We all have been using aspheric IOL and thereby negating the positive spherical aberration of the cornea. However, we came to know that by doing this, we get a better functional vision for distance, but the depth of focus was getting compromised. So certain companies came out with aberration neutral IOL, thereby allowing the positive aspheric aberration of the cornea to focus the peripheral rays in center of the retina and thereby giving us a slightly larger depth of focus or depth of view. Certain companies started with giving the zonal hyperaspheric IOLs like the J&J Eyehance, where the central area is having a higher diopter or higher asphericity than the periphery, thereby giving a slightly larger range of vision in the far intermediate region. So this is where the depth of focus concept started. Then you have IOLs like the Cephei Minivel, where they combine spherical aberrations. The central area will have a positive spherical aberration, the mid periphery will have a negative spherical aberration, and the extreme periphery would have a normal spherical monofocal IOL. So if you see the defocus curve of this IOL, this is slightly better than a zonal aspheric IOL. So we were moving in a better direction. Now they have come with a better version, which is the Xwave Minivel Proxa, which is even giving more near vision. Now we all need to understand one thing. Whatever we do with the physics, the total amount of light entering the eye is same. So if you are trying to get a better near vision, somewhere the distance vision will get slightly compromised. And this is what is happening with all the IOLs where spherical aberrations are being changed. There is reduced contrast. The results are variable because of the dependency on corneal asphericity. It is also a bit pupil dependent, and the need of spectacle is variable. So the amount of consistency is lacking with this IOL, but still it is uh, a step in the direction which the IOL technology is going. You now have a zonal refractive EDOF IOL like the Oculentis, where the superior part is more focused for the distance vision and the lower part is more focused for the intermediate vision. This is just like a conventional bifocal glasses which we had. They have also come with a newer version where the lower part is now working for even near. So one of the IOL will have a 1.5 ad. The other IOL in the lower part will have a +3 ad. However, this has its own fallacy because the orientation is still not standardized. Whether you put the IOL in a vertical direction or the slightly tilted direction to allow the esotropia to come into picture when you are using your eyes to see near. But again, a different technology, a technology which is taking us forward. Now, coming to the optical principles of diffractive IOL, which we probably all of us have used the most. Any kind of diffractive IOL basically works on the principles of sequential diffractive optics, or what we called as kinoform steps. If you see grossly, they are asymmetrical sawtooth profile. And if you see exactly, it is just a step of the size of few microns. Now, what does that step do? The width of the step is going to decide the amount of addition, while the height of the step is going to decide the amount of light energy distribution. So the wider the width, the lower will be the addition. The higher the height, more light energy will be focused for near. There is a certain technology which is called apodization, where from center to periphery, the height of the steps keeps on going down. Now, what that does, it allows more light to be focused on the retina when the pupil dilates in mesopic condition, thereby giving a better distant mesopic view. And this also helps in decreasing the dysphotopsia, which happens with all diffractive IOLs. They started with the conventional bifocal or high head bifocal IOL. Again, one thing to know here is in a conventional bifocal IOL, 40% or 41% light is used for distance, 40 to 41% is used for near. This is again music to the eyes, while the remaining 8 to 20% is noise. So this is what we need to keep a count on. This noise is creating all the dysphotopsia or unwanted visual disturbances. However, the intermediate vision here is compromised, and therefore came the low vision aid IOLs, which we have all used. Again, a very good technology or a step forward, but the near vision was a bit of issue here. So we all as a clinician try to take the technology a step ahead by doing blended vision, or probably doing a mix and match or a micro vision like bilateral EDOF or a bilateral EDOF with Technis bifocal IOLs. However, this all things have their limitation of trying to find out the dominant eye and the non-dominant eye. But still the patients were asking for more. It is like ye dil mange more every time. And that is when trifocal IOLs come into picture. Incidentally, the first trifocal IOL which was launched was in 2010, the same year when Apple launched its iPad. So they say necessity is the mother of all new discoveries, and this happened incidentally. It was started as the first generation trifocal IOL, where if you see, again, the sequential diffractive optics principle was used, where the first step or the aid is at 40 centimeters. So the second has to be the double the distance due to the laws of physics, which is at 80 centimeters. So this gave the functional intermediate vision, while the first step gave the functional near vision, and the remaining light is for distance. Again, what this does is about 84-85% of the total incident light is utilized, while the 14 to 80% still works as noise. This is important to keep an eye on when we are discussing this technology. The first IOL or the trifocal should be credited to Fine Vision. They started it. This was the first design, a hydrophilic one. Now they have come up with a hydrophobic one. This was followed by Acrylisa, which is taken over by Zeiss. Two very good technologies which started the trifocal revolution. However, both of them have their biocompatibility issue because they are a plate haptic IOL with a hydrophilic material. The rates of increased rate of PCO is questionable. The overall diameter being about 11 millimeter, it has its own limitations. However, this was again a step forward. We were all moving to a direction where we wanted better vision for our patients. Then came a path-breaking technology, which is the diffractive EDOF IOL. Again, credit goes to J&J Symphony for bringing this technology. Instead of the diffractive step, what they call the steps are achelates, which try to focus or create a channel of light where the distance as well as the intermediate vision is good, but here again the near vision is compromised. However, this being a diffractive IOL, it had its own limitations. The halo and starbursts were much more than what we anticipated. There was definitely a reduced contrast, though less than a conventional bifocal, but the contrast is still reduced. Susceptibility to tilt and decentration still remains. Then, okay. One more IOL.
Mute yourself. Namrata, mute yourself.
Admin, can you mute Dr. Namrata? Dr. Anand, can you mute Dr. Namrata?
Yes, sir. She's no longer on the. Must
Yeah.
be yeah.
Yeah.
Thank you. Thank you. So then came an IOL, which is probably my go-to trifocal IOL today. And why this is so, I'm just going to highlight few important points about it. One, it is the only hydrophobic IOL which was available present on the same Acrisoft time-tested platform. So no questions about the rotational as well as the stability of the IOL. Very biocompatibility is also quite high and very less PCO rate. One more thing which was important was, especially for Indian population, our normal average height is about 5 feet 7 inches. So normally when you work at an arm's length, the distance has to be about 55-60 centimeters. And that's what these guys did. It was a very smart trick which has happened. We need to just go into it. Normally, if you go by the normal designs of sequential diffractive optics, if you want an intermediate vision at 60, the near vision has to be at 30. However, if it is too near for us to work. So what they did was they got a trifocal instead of, they went into a quadrifocal IOL instead of a trifocal IOL. And they use the principle of non-sequential diffractive optics. So here, the near vision is at 40 centimeters, the intermediate is at 60 centimeters. The far intermediate is at 120, and then you have a distance vision. However, again, if you see the amount of light energy distribution for each distance is 25%, and it would be too less for distance vision energy or seeing far objects, which is a primary thing all normal people do. So again, a touch of genius is what has happened. All the light energy from the 120 centimeter has been converted to distance vision. So now actually we have a trifocal IOL, which was based on a quadrifocal technology, where the fourth step in a quadrifocal IOL has been truncated. What this does is this gives a very good near vision, an excellent workable intermediate vision, where we do all our daily chores, like say putting up a makeup or shaving or reading a label in a supermarket, or probably doing a puja, which is all what or most of our patients require. This has again given us a very good range of vision. If you see the defocus curve, not only the distance vision, even the intermediate and the near vision, it is about 6669. So this is excellent. A lot of the times previously we had to talk about the fallacy of a bifocal or a trifocal IOL as far as the near and intermediate vision is concerned. This has slowly gone when I am now counseling my patients. And the most important part is the IOL is delivering what it is expected to. Again, if you see the focus curve, this is what I have highlighted. The intermediate distance is 60 centimeters here, while the remaining trifocal is at 80 centimeters. It's probably too far as far as what my patients are concerned of. Again, something very important, a class leading 88% total light energy utilization. So the amount of noise, what I was talking about, is only 12%. And thereby, though the number of rings are more, the amount of dysphotopsia is less with this IOL. And this is what we have got a practical feedback from our patients also. Very important thing. One more thing which has changed is the central diffractive area has been increased to 4.5 millimeter. So especially in mesopic conditions, the near vision is relatively better than a normal bifocal or a trifocal IOL. And the distance vision also is better because we have a larger area above 4.5 centimeter, which we have like a monofocal IOL. So few touches of genius which has changed the way the patient is seeing after implanting this IOL. The central bullseye also has increased, and so has the red flagging. We all understand now that astigmatism correction is imperative. All these new presbyopia correcting IOL, the tolerance to astigmatism is just 0.5 diopter. And this is probably where Pantoric is working. The stability is class leading about the IOL. And so again, I am able to implant more trifocal IOLs in patients with astigmatism and able to deliver better. And these patients really get more satisfied because they have been using high astigmatism glasses for years together. So for them, this is something which is very welcome step. Again, J&J has got one step forward. They have combined a traditional bifocal IOL with their diffractive IOL, which is Symphony, to give us synergy. They claim that the range of near vision has slightly improved. It is more up close. However, what happens is when you use two technology, it has got its own limitation about dysphotopsia, which we would be discussing. The last but not the least is the wavefront shaping path breaking technology, which has come to fore. It took me a bit time to understand what exactly this is. So I'm just trying to delve into it. If you see a normal Gaussian beam, this is the laser beam which is getting focused on any kind of wall or metal. Because of the Gaussian beam profile, if you see, the rays would be passing in a particular pattern. Now, what they have done is they have used a wavefront shaping diaphragm in front of the anterior surface of the IOL, and thereby you get a punched hole rather than a Gaussian beam. And this is what is being used or called as a wavefront shaping technology. What they have done is they have kept the same accuracy of platform. The Xwave technology is nothing but stretching and shifting the same wavefront by using a kind of a diaphragm or a surface. The light is actually never split. This is what is important, because this helps us to prevent all kinds of dysphotopsia. And what we have is the Alcon IQ VVT. What exactly they have done is, in the center area, there are two transition zones. The center transition zone is about 1 micron height, and it stretches the wavefront or the light which falls on it. The mid periphery, which is the second transition, is at about 2.2 millimeter. And what this does is it shifts the wavefront. Now, when light falls on the anterior surface of the IOL, the two surface transitions work simultaneously and synergistically. And when the light passes through the lens and falls on the retina, what this does is the wavefront, though the central part delays the light, the peripheral part hastens the light. So the delayed wavefront gets focused in the near end of the tunnel, while the distance end is focused at the distal end of the tunnel. So instead of a point focus, we have a tunnel, again, which I was talking about, an area where the maximum light is focused. And the tunnel width is really small. The amount of light going out is bare minimum. So what all we required from a multifocal or a presbyopia correcting IOL, most of the marks are ticked here. What this does is gives a very good distance vision, very good intermediate vision, and a relatively good functional near vision. And this is important because when a bilateral summation happens, what I have seen with my patients with the limited experience, though I had my apprehensions, and it is, we tell our patients that you might require near vision aid. Most of our patients with bilateral summation do get a very good near functional vision. So as of now, this is one of my go-to IOL when I talk about an EDOF technology. Again, the halo profile of the Alcon VVT is as good as a monofocal IOL as compared to the diffractive technology. When you look at the presbyopia correcting IOL as a whole, if you see carefully, the Technics Symphony has got two sweet spots, but the near vision is lacking. The Panoptics has got three sweet spots, the intermediate, near, and the distance vision. And the VVT with the Xwave technology has got consistent tunnel without any depression or without any lag. Though the near vision is slightly less, but I have got an IOL where I am able to probably not worry about those rings and halos and dysphotopsias, which we talked about. Now, this is just a basic about what happens with all kind of technology. If you have a diffractive bifocal or trifocal, you are going to have halos. If you have a EDOF technology, you are going to have starbursts. And this is what I was talking about. When you combine a diffractive and an EDOF technology, you will have starbursts and halos both. This is my last slide. As sir was trying to tell, I have gone through all sorts of IOL which are coming in the pipeline, and I have lost the count. But what I have come to a conclusion is, if you try to get a larger range of vision, somewhere the dysphotopsia profile is being compromised. So what I am looking for is a compromise between the range of focus and the quality of vision, which is happening presently. I hope that in near future we get an IOL which is able to give us the highest range of vision as well as the least dysphotopsia. Thank you.
Thank you, Nishant. That was very comprehensive